kg per meter square. Pulse 84 beats per minute. Blood pressure is 120 by 70 millimeter of mercury. Temperature 98 degree Fahrenheit. Respiratory rate 18 beats per minute. There is no pallor, koinonia or clubbing, no jaundice, and skin discoloration of the conjunctiva. The oral hygiene was satisfactory. Thyroid was not enlarged. Accessible lymph nodes not palpable. There was no pedal edema or viscosities in the legs. On her breast examination, there was bilateral normal looking, no mass palpable in all the 4 quadrants of the breast, no lymph nodes palpable. Series of first and second heart sounds was audible with no added sounds or murmur. JVP was not raised. Her normal respiratory system had normal vesicular breathing with equal air entry on both lungs. On abdominal examination and inspection, the abdomen was protuberant in the lower right side, umbilicus central. All stria gravidarums were present, and there were no visible pulsation, no scar marks. All hernia orifices were intact. On superficial palpation, there was no tenderness. On deep palpation, a 16 to 18 week size mass on the right eyelid fossa, which was cystic in consistency, smooth surface, regular margins, mobile from side to side. The lower limit of the mass was reachable. Right flank was dull on percussion, where I felt the mass. There was no shifting dullness. The left flank was resonant. On pelvic examination, the vulva was normal looking with normal hair distribution. On first speculum examination, there was no discharge. No discharge was present. Cervix was normal looking. Pap smear was taken. On bimanual examination, uterus was anteverted, 8 to 10 week size, mobile, non-tender, felt separately from the mass. There was fullness on the right fornix. A mass of 18 week size was felt, which was separate from the uterus. It was mobile, cystic in nature, and non-tender. No mass was felt on left side, and there was no tenderness.
Good. You have 6 minutes, right? And what about investigations? Do you have investigations?
No, sir.
What investigations will you have?
I'll have the baseline investigations.
Baseline. क्या baseline क्या कराएं?
Blood group.
जी.
Sir, complete blood count. So in which I would like to have hemoglobin.
Complete blood count कह दिया आपने, ठीक है.
Urine complete examination.
Urine complete examination.
अच्छा, beta HCG.
Beta HCG.
BSR.
BSR. Beta HCG आपने baseline investigation में कही. BSR.
Hepatitis B surface antigen anti-HCG.
Hepatitis markers. ठीक है. और क्या कराएंगे आप?
सर स्पेसिफिक में आ जाते हैं.
जी स्पेसिफिक.
स्पेसिफिक में सर I will go for ultrasound. सर इन्वेस्टिगेशन में ultrasound. pelvic and abdominal ultrasound सर.
Okay.
क्या क्या चाहिए?
चलें और अब नाम ले लें फिर आगे चलेंगे.
सर I will ask for tumor markers.
Tumor markers. Okay. कौन-कौन से tumor markers कराएंगे आप?
Sir CA125.
CA125.
Beta HCG I have already discussed.
Beta HCG. जी.
And alpha fetoprotein.
Alpha fetoproteins. जी.
Or sir, if it's malignant, then I'll go for a CT and MRI.
How would you know whether it is malignant or not just on examination or on these investigations? Shall we now start discussion? Because you've told about the examination also and any other investigation you would want to have at this stage.
So it depends on the reports of the they depend on reports of hemoglobin. If the hemoglobin is low, then I will ask the serum indices and the serum ferritin.
Right. And okay. No, not arising from these reports, but any other apart from that. Not that I'm not asking because I think that there should be more investigation, but is this the complete list that you would want to have right at this
So by
stage?
the history and examination, it seems to be benign. But if there are chances of malignancy, then I will ask for extra chest.
All right, we will start from here. You say that if it is malignant, okay, what are the clinical features of benign or malignant ovarian tumor?
So clinically, there is mass in the abdomen or the pain.
Mass in abdomen is present in both. Well, let's talk about the clinical features of possible malignant ovarian tumor.
So the ovarian tumor will not be done, will be multiloculated, solid.
The multilocculation is something that you come to know on ultrasound. Clinical features.
It will be, it will not be movable. It will be hard in consistency.
Right. Okay.
So can we say that it could be firm? Like the cystic mass, we feel it's cystic or soft? Or
I would say that it is better to say that solid. What you assess on examination, it is a solid looking tumor.
Solid.
So that is what you want to say.
Yes, it is solid looking.
It's more often solid, although there are benign solid tumors as well, but it's more likely to be solid. So anyway, this is one question that should be answered straightforward about clinical features, and or if you broaden it a little bit, it can be features of malignancy on history and physical examination, or before operation features of malignancy. Because final diagnosis will be not only at the time of surgery, but also at the time of with the report of histopathology. So if you look at some of the points during history, those are sudden onset, rapidity of growth, that over a short period of time, the small tumor has become larger. Features like pain, although that can be there in benign tumors if there is torsion or there is some complication like that. And rapidity of growth, it's being more likely it's solid, bilateral, rather fixed, not mobile. These are some of the features which on clinical examination you will find. Then on ultrasound, you find that it is solid or multiloculated. There is presence of ascites, if that can also be assessed on physical examination. And even at the time of surgery, then there are certain features, for example, again, adhesions, large blood vessels on the surface, etc. Those are the features. So, all right, you think that it is more likely a benign tumor. You have asked about ultrasound. What are the features on ultrasound that you would want to see?
So regarding the mass, or I have to.
You are going to order ultrasound for this patient.
Yes. And
in the ultrasound report, what are the features that you would particularly look for?
So I'll ask first. I will ask for the size of the uterus, the uterine thickness, then either the mass is present or not. If the mass is present, then
mass तो present है ना, उसको अब क्यों mass
unilateral
ultrasound वाले के पास जाता है mass गुम जाएगा.
So ठीक है, the unilateral or bilateral, whether it is cystic or multiloculated solid, papillations are present or not, the surface of the mass.
आपने यूट्रस का साइज भी मालूम करना चाहा, आपने एंडोमेट्रियम भी मालूम करनी चाहिए, उसका क्या सिग्निफिकेंस है?
So it can be fibroid. There is possibility of fibroid too. वैसे तो मैंने रेशिया वगैरह नहीं है इसमें. Fibroid,
आपने अपने एग्जामिनेशन में कहा that you could feel this uterus separate. 8 to 10 weeks size आपने कहा, और you said that it is mobile and you can feel it separate from that. So फिर fibroid क्यों कह रहे हो? और आपने ये भी कहा कि वो mass cystic है. तो फिर आप फाइब्रोइड की डिफरेंशियल डायग्नोसिस कहां से ला रहे हो? मैंने अब दोबारा से मैं सवाल आपसे पूछता हूं कि ऑन अल्ट्रासाउंड व्हाट आर द फीचर्स दैट यू वुड वांट टू पे अटेंशन टू?
Sir, Regarding the mass, I will ask whether it is cystic or solid. It has septors are present. It is unilateral or bilateral. Whether it is
you wouldn't say bilateral. You would want to know about the status of the other ovary, right? Because you have yourself on examination said the expectation or the request that you send for ultrasound should be in line with what you have assessed on physical examination. Since you said that the other fornix was okay, so therefore what you want to know is the appearance of the other ovary on ultrasound, whether there is a small cyst which you couldn't find on that physical examination, so you want to assess that. But what you would say that you would want to know the size or assessment of the other ovary on ultrasound, okay? And you don't move from here to there. First, you mention the features of that particular mass, then you move on to the other side. Now, in this mass, you would want to know about whether it is cystic or solid. If it is cystic, either it is multilocular or it is unilocular, whether it has got any papillary projections or any solid areas within it. What else?
the size of the mass.
Size of the mass, all right. You have a fair idea of the size of the mass, that it is 16 to 18 week size. So you have a fair idea of that. All right. What more?
The intelligence.
No, within the, about the mass.
About the mass.
Do you want to know about the
muscularity
of the mass? So those are the considerations. And if it can, ultrasound can inform you about any adjacent structure getting attached with it or any other abnormality, right? All right. So what will be your plan of management of this patient? And tumor markers, all right. What do you expect CA125, beta HCG, and alpha-fetoproteins to be? She is 35 years of age. What is the significance of beta HCG and alpha-fetoproteins?
So these are tumor markers which will tell the.
And which type of tumors are these affected?
So beta HCG, that is raised in say choliocarcinoma and
trophoblastic tumors. Yes.
Or alpha fetoproteins, they are raised in teratumors or teratumor and yolk cell tumor. Beta HCG raised in choliocarcinoma. Choliocarcinoma.
चलो हो गया आप आगे चलो.
Sir, they are raised in choliocarcinoma.
CA125.
These are the epithelial cell tumors. Serous cell.
Serous particularly. Epithelial. Right. And there is another tumor marker, CEA.
So these are likely, they are more likely raised in pancreatitis, so they are maybe raised to the significant.
Right. So if it is secondary tumor usually, then that is. Someone has said germ cell tumor. That's right.
Yes, sir. Inhibin is the tumor markers in.
Okay. Okay. All right. What is your plan of management for this patient?
So first, I will counsel the patient that by the history examination and the investigation.
There is one point that that I would want to know in history. You said that her younger child is 5 years old.
Yes.
Following that, what are their plans? Are they using contraception, or do they have to plan? Do they have plans for another pregnancy or not?
They are using contraception, but they have the.
They haven't used any contraception.
They haven't used any contraception, but sir, they are because both of them are girls, so they are planning for the next pregnancy.
Yes. Now that's an important point again. You see, when you told about the obstetrical history, you did not mention the gender of the children at that time. So that was missing. Then no contraception, but at the same time, there should have been a mention about the plan of pregnancy.
So you obstetrical history mentioned.
Contraception is part of the gynecological history, and there at that time you should also mention that the couple hasn't practiced any contraception and they are planning to have a child, and also whether they have had some treatment for infertility or not. Because if for 5 years they have not used contraception, that means they are planning a child, particularly if they have had previously 2 girls only. So whether they have had any treatment or not, and if they haven't had any treatment, what is the reason? So that is something which is relevant and will come handy when you start discussing management of this couple or of this patient. Okay. So your plan of management?
Sir, by history examination and
वो आ गया उधर differential diagnosis की बात आ गई. Differential diagnosis का वो बता दे differential diagnosis आप.
Sir, the ovarian cyst. सबसे पहले होगी sir ovarian cyst, then tumors. It can be ovarian tumors. Cyst may be
ovarian tumor को हाँ.
Benign or malignant. So they can be ectopic pregnancy.
Ectopic pregnancy इतनी मोबाइल अब फाइब्रॉइड पहले कह लो ना, आपने कहा हुआ है फाइब्रॉइड दोबारा से. मैंने तो नहीं कहा कि आपने कहा कि फाइब्रॉइड. ectopic pregnancy जब हम डिफरेंशियल डायग्नोसिस की बात कहते हैं तो उन्होंने जिस तरह से कहा they want to know what masses can be there. वैसे तो डिफरेंशियल डायग्नोसिस में all the masses that can arise from pelvis and all the masses that can be there in the abdomen, which would of course वो उसमें हाइड्रोसाल्पिंग्स भी आ जाती है, पायोसाल्पिंग्स भी आ जाती है, वो ट्यूबोवेरियन मैस भी आ जाता है. ये जो आप कह रहे हो वो है, लेकिन पहले जब ओवेरियन ट्यूमर आपने कहा है क्योंकि आपने एग्जामिनेशन कर लिया है, तो उसके बाद वो जो आपकी डिफरेंशियल डायग्नोसिस है वो कंपैरेटिवली नैरो हो जाती है. If we are just theoretically discussing mass, a cystic mass in the or a mass in the lower abdomen, then all those 15 masses there which can arise from the pelvis, or all those 15 or 20 masses which can arise in the abdomen, they will be kind of mentioned. But if you have taken the history and if you have examined the patient and you also have carried out certain investigations. Now, investigations, since we do not have the report of ultrasound with us, we can only say that history and on examination, then the differential diagnosis would narrow down. Then it will not be a biosalpinx, it will not be an ectopic pregnancy, as you say, and it will not be a retroperitoneal mass. It will not be a tubo-ovarian mass because it is mobile, you said. It is mobile from side to side, from up downwards. It is separate from the uterus and all that. So therefore, it will be the differential diagnosis that we discuss will depend upon the stage at which we are discussing that. That is, before we have history examination or we are just discussing it theoretically. So इसमें आप ovarian tumor कह सकते हो, fibroid आप कह सकते हो, pedunculated subserous fibroid, वो आप उसको कह सकते हो, that may have undergone degeneration, but that is quite a stretch of imagination to have a cystic fibroid, which is that's why you place it lower down on the list. What else can it be there? Some abdominal? Can it be a retroperitoneal mass? Would you mention that?
No, sir.
Why not?
Retroperitoneal mass.
मोबाइल नहीं होगा ना भाई, साइड बाय साइड से, नीचे से ऊपर से. जब मैं व्हाई नॉट पूछता हूँ, इसका ये मतलब नहीं है कि आप गलत कह रहे हो. So इसका वो है कि retroperitoneal mass is not mobile like that. Therefore ये इस तरह से होगा ऐसा. ठीक है. So इसमें आपका जो differential diagnosis है वो narrow down हो जाएगा. Dr. Sapna Kumari, if you have some other differential diagnoses, please write them down. Thank you very much for asking that.
So can it be appendicular mass?
Appendicular mass would rather be fixed. वो rather fixed. वो abdominal masses में से आप बात आ गए, तो उसमें वो हो गए और उसकी preceding history होगी, कोई के appendix का हुआ था, उसको temperature हुआ था, pain हुआ था, वगैरह वगैरह, तो वो आ गया. चलेगी. अब आ जाए मैनेजमेंट की तरफ. उन्होंने LDH भी कहा है. वैसे मैं वो तो देख रहा था कि LDH के इसका सिग्निफिकेंस देखो, सहरजारा ने कहा है कि LDH भी कराएंगे। अब LDH हर चीज में आ रहा है, कोरोना से लेके जो भी चीज ढूंढो तो उसमें LDH आ गया है। जी सपना कुमारी हमसे एग्री कर रही हैं कि आफ्टर हिस्ट्री एंड एग्जामिनेशन, सो इट इज इम्पोर्टेंट, यू सी द पॉइंट हियर टू रिमेंबर इज that the discussion about differential diagnosis will depend upon, as has been said twice already, depends upon at what stage of management or examination or history we are talking about the differential diagnosis. Okay ji, let's move forward.
Sir, by history and examination, the mass seems to be the benign. I will counsel the patient that by history and examination is.
अब मैं काउंसलिंग के बारे में बात करना चाहता हूँ. That's an important, because we start faltering at the time of counseling. हम क्या देते हैं कि we will counsel the patient. Now, this is something which in future, when you present a case, you should have definite points of counseling written down, or at least you should have notes about that you will talk about. Ji.
Sir, I will counsel the patient. On the stick that we have counseled the patient, the mass seems to be benign, and the mass is large enough that it cannot be treated by the medications. So we have to.
Is a smaller mass can that be treated by medication? For example, what kind of ovarian?
Like conservative management, that can be treated by conservative management. But in case of this large mass, this cannot be treated by conservative management. So we have to surgically remove the mass.
Okay.
Either by laparoscopy or by laparoscopic surgery.
Laparoscopic surgery, खाम में दरमियान में ले आए हो इतने बड़े मैच के लिए.
क्यूसिस्टिक होगा तो सर हो जाता.
मतलब अभी वो हम मोडेलिटी उसकी बाद में लेप्रोस्कोपिक सर्जरी, वो कहता है लेप्रोस्कोपिक सर्जरी करो. मैं फिर आपसे पूछूंगा कि अब मैं आगे वाले सवाल में इस टाइम पे नहीं पूछना चाहता हूँ.
सर आप बैठ मुझे मार होता है. लेकिन सर लेप्रोस्कोपिक सर्जरी क्यों वो ड्रेन करके कांट ही रिमूव है.
What are the pitfalls of draining tumor when you don't know it's malignancy or otherwise it's benignity or malignancy? ऐसे हम अच्छी बड़ी हिस्ट्री और एग्जामिनेशन कर आगे एंड में आगे वो आप उधर स्मार्ट बनने की कोशिश करते, चालाकी मत दिखो. ये वाला जो था ना कि मैं लैप्रोस्कोपिक सर्जरी भी काम लैप्रोस्कोपिक, अभी उसका मौका नहीं आया. आप जब हम जाएंगे तो फिर हम जब अप्रोच की बात करेंगे फिर आप बोलो कि जी हम इसको ये कर देंगे वो कर देंगे, जिस तरह से करोगे, एंडो बैग में लाओगे, कैसे लाओगे, मिनिमल एक्सेस सर्जरी होगी, रोबोटिक सर्जरी होगी, आप सारा कुछ बोल सकते हो. लेकिन अभी तो टाइम नहीं है. आप उनको मुझे अपने पॉइंट्स बताओ काउंसलिंग के. काउंसलिंग में आपने बताया कि जी सर्जरी की जरूरत है. हाँ जी, आपने कहा सर्जरी की जरूरत है और ऑपरेशन होगा और उसको रिमूव किया जाएगा. नंबर 1. नंबर 2 और क्या बताएंगे आप?
सर सर्जरी मतलब सर वो भी बता सकते हैं कि देयर आर चांसेस 5 to 10% चांसेस होते हैं कि कैन बी मैलिग्नेंट. तो उस केस में क्या करेंगे?
क्या करेंगे आप? 5 to 10% आपने कहाँ से ले आए हो? Where are you quoting this figure of 5 to 10% of this being malignant? कौन सी ट्यूमर का 5 to 10% malignancy का चांस है? At what age?
टेराटोमा से less than 40 years.
हाँ तो ये टेराटोमा.
So there are chances of being malignancy.
मैं तो कह रहा हूँ नहीं भाई, मैं नहीं कह रहा malignancy का, लेकिन आप परसेंटेज पेशेंट को क्यों दे रहे हो? आप क्या करना चाहते हो? आपने कहा कि सर्जरी होनी चाहिए, दूसरी क्या करोगे आप? अब सर्जरी करके क्या रिमूव करोगे? You will remove the tumor.
Yes.
Will you remove the tumor or will you what kind of surgical procedure will you do? You do laparotomy, right? And what incision do you give?
Midland Incision.
Midline incision. So आपने remove करना है ओवरी को, ओवरी के साथ ट्यूब को भी, या सिर्फ सिस्टेक्टमी करनी है आपने? क्या करेंगे आप? ये काउंसलिंग में आपने बताना, मैं पूछना चाहता हूँ।
ये रिप्रोडक्टिव एज है तो कंजर्व करेंगे ओवरी फ्लोपियन ट्यूब। आई विल ट्राई टू कंजर्व द फ्लोपियन ट्यूब एंड ओवरी।
अच्छा, you will try to conserve cystic mass, which is about I would imagine it must be about 16-18 centimeters in diameter. If it is rising up to 16-18 week size, तो इतना तो होगा वो। अगर इतना हो तो उसमें ओवेरियन टिश्यू बचाना जरा आसान नहीं होगा। लेकिन आप फिर दोबारा से कंफ्यूज कर रहे हैं हम मैनेजमेंट को और काउंसलिंग को। काउंसलिंग में आप कहेंगे सर्जरी होगी, और नौयत बताइए सर्जरी की क्या करेंगे आप? उन्होंने फैनल स्टील एंड सीएन लिख दिया। चलो
मिडलैंड इंसिजन देंगे।
ओके, आप मुझे काउंसलिंग में बताओ, हम मैनेजमेंट पे नहीं जा रहे थे। काउंसलिंग में आपने कहा सर्जरी होगी, आप ट्यूमर को रिमूव करेंगे, राइट?
then I send the wall for histopathology, और अगर histopathology जो है that is benign, then we leave it as it is, और अगर तो tumor होगा then we counsel the patient again for reopening.
रीओपनिंग का लफ्ज मत बोला करो। ये पेशेंट को खोल के देख लेना। यू आर टॉकिंग टू द पेशेंट, सो द लैंग्वेज दैट एंड द वर्ड्स दैट यू यूज, दो शुड बी केयरफुल। नहीं, अभी आपने काउंसलिंग की बात नहीं कर रहे, कंफ्यूज कर रहे हो। काउंसलिंग प्लीज वंस अगेन। So everyone, ये अभी हम we move on to the next point, but I'll want the participants to write 4 or 5 points of counseling that they will carry out with the couple, and then we'll come back to that in a little while. All right जी, अब मुझे सर्जरी का बताओ कि आपने फिर इसकी सर्जरी करनी है या कंजर्वेटिव मैनेजमेंट करनी है या
सर्जरी एज अ साइज।
ओके, आपने कहा कि आप मिडलाइन इंसिजन देंगे और फिर क्या करेंगे आप?
मिडलाइन इंसिजन देंगे, enter into the cavity and I will remove the cyst.
You will remove the cyst and then you will run away?
नहीं, I practically क्या करते हो?
Practically आप क्या करते हो?
तो वॉशिंग वो सारा सब वो बताएंगे। चलो ओपन
नहीं, वो नहीं बताना, वो कहाँ का है वो बताना। हाँ, क्योंकि वो अगर बता दिया तो शायद तुम पास हो जाओ, और वो और तुम पास होना नहीं चाहती हो, इसलिए तुमने क्यों बताना?
If there is a side effect, I'll take the because scan में तो नहीं आया, और अगर नहीं होगा तो then I will take the washing.
तुमने बात सुने ये, all of you who are attending this, what happens is that most of the candidates in these mock sessions, they are very good with their history, they are very good with their physical findings, and also to great extent the investigations part as well. But when it comes down to practically managing that patient, and suddenly you would find that the volume of their voice goes down, then they start faltering, then they would go from here to there. In such cases, when the history has already been taken and you have managed or kind of read about the case, you should also write down the management. And management in terms of its counseling points of counseling, because the more often that you do it, you will get practice, and then in that examination situation, then those points will automatically come handy for you. And in addition to that, then you move forwards, and you then should write down or have in mind the points in the rest of the management. If it is an operative procedure, then the steps of those operative procedure. Not that you will cut the skin and then the subcutaneous fascia, but the major steps that you are required to know. For example, in this, what you do is that after you have given the abdominal wall incision and you enter into the abdominal cavity, what do you do first of all? You inspect the organs. You see whether there is ascitic fluid or not. And if it is there, then you aspirate the ascites and save it for cytopathology. And in addition to that, then you examine not only that tumor, you examine the pelvic organs, you also have an assessment of the general peritoneal cavity. If it is an ovarian tumor and someone had very rightly that has gone up, said about staging laparotomy, that is a word which you should be using whenever you are operating on a suspected ovarian tumor. So you call it staging laparotomy.
Sir, in this case, we know it's benign. तभी हमें ऐसा ही करना है.
कैसे आपने आपको 5 to 10% अभी आपने कहा कि malignant हो सकता है.
अच्छा हम स्टेप्स वही करने वो वॉशिंग वगैरह
तो क्यों नहीं अगली बातें करते हो तुम. अगर let's say the patient is 15 years old और cystic mass है तो क्या करोगे तुम उसको. अगर तुम्हें ये नहीं पता तो फिर तो बड़ी गलत बात है. वो on history and examination it looks benign, but final diagnosis will be intraoperative and on histopathology. So you call it whenever you are performing a laparotomy for ovarian tumor, you would nowadays call it a staging laparotomy, because the stage of and diagnosis of final diagnosis of that will be carried out only through the operative procedure and the biopsy that you make out of it. But that's an important aspect. So this is all what you do at that time. And you see, the assessment in the examination is only about this. You can talk a lot of theory, still you can fail. But this is the time at which you would then be telling about the management that you have learned and that you have carried out, that will make the difference in the examination result. Zahigul, you are correct in that question. Although it's all, that's what our candidate here also assumes. But what we call this is a staging laparotomy. Just naming it staging laparotomy does not mean that we are labeling it as a malignant tumor or a malignant issue. Staging laparotomy can lead to, and obviously in most of the instances in comparatively younger patients and in situations like this, will result in the outcome being a benign one. But we still will call it staging.
Hello.
Anji.
Sir, what about the incision? We'll go for the midline incision or the financial incision?
Technically speaking, if you are going to, you are making a stage, or you are doing a staging laparotomy, it has to be a midline incision. And in examination, although I may myself be making a transverse incision, but in the examination, I would want you people, if you are to take the examination, to make a midline incision, because that is extendable and that will afford you the opportunity of assessing the peritoneal cavity.
Thank you, sir.
Also, you remove the mass intact.
It's important because in Phenon steel incision, it may not be possible many times to remove the mass intact, and if you can't, and if you rupture the cyst, then that will obviously alter the staging of the situation, and that would be an unfortunate, situation. We all face it from time to time, but that certainly changes the stage. Can anyone tell me what is the stage if at surgery you make a spill? बता सकते हो?
1C.
Yes, 1C1, because 1C is now divided into 1C1, 1C2, 1C3.
1C1.
1C1 is when there is surgical spill. 1C2 is when there is the capsule is broken, and 1C3 is when there is when there are malignant cells in the ascitic fluid. So that is 1C1, 1C2, and 1C3. So if you spill there is surgical spill, it will be 1C1. All right.
So I will take the washing. I will examine the mass for the surface, whether it is cystic or cystic or it has.
वो हो गया कि आपने mass को कर लिया.
Then I will see the contralateral ovary, the status of the contralateral ovary. Then I will see the pouch of Douglas if there is involvement of the pouch of Douglas, or then the intestine.
What kind of involvement of pouch of Douglas?
So they pouch several spread the tumor you have also the pouch of Douglas. If there is a chance of if it's tumor.
If it's a tumor.
Yes.
तो ये क्या है?
Malignant tumor.
Malignant tumor. अच्छा और?
Or I will see for the intestines and the other organs.
Or what are other organs?
The bladder or bladder. Just locate to the exercise.
वो तो देख लिया आपने कल और
intestines, large intestines, small intestines, and then I will see for the lymph nodes involvement.
एक जो चीज है उसका जिक्र आपने नहीं किया जो सबसे पहले होना चाहिए था बाकी चीजों उसको बोलते हैं मोमेंटम. आप जब एब्डोमेन में देखना चाह रहे हो जब आप इसका एक लिस्ट बनाओ आप लोग अगेन फ्रोजन सेक्शन पे भी आ जाते हैं उसकी बात भी करते हैं इसकी लिस्ट बनाओ that you will, in what order will you go about, because you see the pelvis first. You can make a list of the pelvic structures and then you go in the abdomen, and in the abdomen momentum comes first, then the intestines, the peritoneal, then the peritoneal surfaces, the parietal peritoneum, the peritoneum under the diaphragm, and all along with that liver. And then you talk about lymph nodes, right?
Yes.
अब मैं आपसे पूछूंगा what is the lymphatic drainage? बोलो.
The paraortic lymph nodes.
बस.
That's paraortic lymph nodes, inguinal lymph nodes.
Inguinal lymph nodes कहाँ से आ गए? Inguinal lymph nodes कहाँ से आ गए? हाँ? बनाओ एक लिस्ट बनाओ of lymphatic drainage, which is uterorenal, infundibulopelvic, ovarian, and another route of through external iliacs, and part of that external iliac will go to internal inguinal lymph nodes तक जाएगा. Yes, scrapings from undersurface of diaphragm, but also when you are you obviously suspect that, then patchy or many biopsies from even normal looking parietal peritoneum. But of course, if it's you suspect malignancy, then, and part of the omentum also, of course. How to take scrapings from undersurface of diaphragm? I haven't done it myself. I am not an oncologist, but you have to therefore make a longitudinal large incision, a vertical large incision, and reach the diaphragm and take a small biopsy from that. Scraping is comparatively easier if you want to take only scraping, but I haven't read anywhere scraping. I have read only biopsy from the undersurface of the diaphragm. Lymphatics, uterorenal, that's one, infundibulopelvic and ovarian, and an indirect route through external iliac. इसके रेफरेंस के लिए मैं अभी आपको एग्जैक्टली बता देता हूँ. Uterovarian and fundibulopelvic, round ligament pathways, and number 4 is an external iliac accessory route into the regional lymph nodes, which would be external iliac, common iliac, hypogastric, lateral sacral, para-aortic lymph nodes, and occasionally to the inguinal nodes. The peritoneal surfaces can drain through the diaphragmatic lymphatics and hence to the major venous vessels above the diaphragm. Now, you see, these days when you talk about the ovarian tumors, that is not the correct terminology. It is the tumors of ovary, fallopian tube, and the peritoneum. Because majority of the ovarian tumors, so-called ovarian tumors, and particularly serous tumors, they arise from the fallopian tube. And some people also use the terminology of Mullerian duct tumors. But I'm not saying that is something which should be used. And the important genesis of these tumors is also endosalpingiosis. Endosalpingiosis is a condition which is akin to endometriosis. And it is when endosalpinx like epithelium is found in places other than the inner lining of the fallopian tube. That is endosalpingiosis. And that is one of the major features or major sources of these tumors of ovary, fallopian tube, and the peritoneum. Hina Patak mentions infracolic omentectomy and not supracolic. We haven't really gone into that because we are not at the moment discussing the full malignant ovarian tumors as such. And frozen section, yes, it was raised at another time also. If it is a completely cystic tumor, I would rather be hesitant in taking a frozen section, because in that case, I would perhaps be rupturing the tumor and changing its staging. Yes, if it is a solid tumor, then by packing the area, or if it is unresectable, then. So therefore, at that time, I will take into account, at the time of surgery, I will take into account the age of the patient, the desirability of preserving fertility function, the status of the tumor, and whether it apparently, clinically, again, looks to be benign or malignant. Yes, frozen section is available here on special request. We have to call in a specific lab, and they would send in a person, and then that is done under special arrangements. So therefore, we'll talk just about a comparatively simple ovarian cyst today, and we'll leave the malignant tumors management to another day, maybe within a week or 2 weeks' time. Then I will I'll prepare that presentation and give it to you, right? About management of ovarian tumors, about whatever we've been discussing a little bit. All right. Examiner usually asks that, and we have never seen. Can you lymphatics? Okay. Infracolic omentectomy.
So what is also diagram?
How to take scraping. All right. Let me also get information about that, and then I will let you know about that. Diaphragmatic. These days, I think that YouTube should be helpful. Yesterday, I was trying to make I was preparing a presentation, and I just stumbled onto anatomy of the pelvis, and I started collecting drawings of pelvic anatomy. I thought I should renew my knowledge of pelvic anatomy. So I went on to look for the blood supply, the nerve supply of the pelvis, as well as the anterior abdominal wall. Who is going for endoscopic surgeries these days, because Dr. Sohail very much wants all of you to know pelvic anatomy's detail. So try to familiarize yourself. All right, जी, चलो अब final करो इसकी.
सर इस केस में सिस्टेक्टमी हो सकती है
तो आप मेरे से पूछ रहे हो, मैं तो पूछना तो मैंने आपसे था, इम्तिहान मैं दे रहा हूँ, आप दे रहे हो.
मेरी का आपसे खत्म कर दिया
नहीं.
सर बस इस केस में वो फॉर सिस्टेक्टमी.
अच्छा, मैं now this is let me kind of summarize this, the management. So far as counseling is concerned, I will have the couple in front of me, and I will tell them that this is a tumor of most likely a tumor of one of the ovaries. There are two ovaries and there are two tubes. I'll tell them a little bit of the anatomy. And this tumor is likely involving the whole of the ovary, and shelling it out and leaving behind some viable ovarian tissue may not be possible. So in all probability, number one, that she'll have laparotomy, she'll have an abdominal operation. Number two, that that tumor side of ovary and the tube, those will be removed, because if you're removing the ovary, there is no point in leaving behind the tube, and the tube may be the culprit in itself. That will be removed. Since you are concerned about having another child, we will leave behind the other ovary and the other tube. Even if that tube is an issue or a problem, with the remaining ovary, you can still have possibility of a pregnancy. So this is the kind of treatment that you will tell them, that she needs surgery. It will be a laparotomy. It will be removal of the tube and the ovary. And number four, the fertility will be preserved. She will not have hysterectomy and the removal of the other side of the appendage. And then we will send, it's a routine that we send, because we do not want to raise undue alarm. That it is always a routine that whatever specimen we collect at the time of surgery, that is sent to the lab for its assessment, what is known as histopathology. And any further treatment, whether medical or the possibility of which is very small, of further surgical intervention, is made on the report of the histopathology. And when that report comes, I will once again discuss with you the implications of that, and then we will go forward according to that. The possibilities can be that nothing more will be done, and other possibility is that if some other treatment may be required, but that we will discuss only after we get the report. So this is the kind of counseling that I would take up with that. Counseling points were started. Number one, that this is a tumor of the ovary where the eggs are formed, most likely. Number two, it requires surgery. Number three, it requires removal of that tumor, and with that, most likely removal of the tube and the ovary. The next, the reproductive function will be preserved because we will leave behind the other tube and the ovary. Next, the specimen is sent to the lab for histopathology. Next, further management will depend upon receiving the report of histopathology, which is likely to be good, and in all probability, nothing more will require to be done. This is the counseling that I will do. And this is what I will manage her in terms of surgery. That will be a midline incision. After opening the abdomen, I'll see whether there is free fluid, ascitic fluid, or if it is not there, then I will take peritoneal washing, irrigate peritoneal cavity and take the washings, and collect that separately for cytopathological examination. Then inspect the general peritoneal cavity, the pelvis, uterus, the other ovary in the tube, and this mass, momentum, palpate it, feel it, the intestines, any evidence of some deposit. And according to the textbook, you also visualize the undersurface of the diaphragm. I generally do not, I'm not saying that this is what you should say. I personally do not make that big an incision to see the undersurface of the diaphragm. If the momentum looks all right, if the intestine looks all right, I confine myself only to those aspects. And probably this is what you can say, that you are working in an obstetrics and gynecological unit, and you haven't worked in an oncology unit. You haven't seen an gynae oncologist operating, but these are the steps which are written in the book, but you haven't seen it. That's it. ठीक है जी. About borderline tumors and malignant tumors, I'll take that up in a future presentation. बाकी पर्दा सीमे पर मुलाहिजा फरमाइए. इसका मतलब समझते हैं आप? नहीं नहीं, इसका मतलब वो आजकल आप टीवी वाले और वो इस तरह की चीजों में नहीं समझते. पहले जमाने में होता था कि वो जब फिल्म आती थी ना कोई नई, तो उसका एक राइट अप सा आता था कहीं पे, वो स्टोरी का उन्होंने जो ट्रेलर वाली स्टोरी होती है ना, उतनी उन्होंने उसमें लिखी होती थी, और एंड में जाहिर है बाकी तो सारा कुछ वैसे होता है. तो उस पे होता था बाकी पर्दा सीमी पे, वो स्क्रीन बाकी पर्दा सीमी पे मुलाहिजा फरमाइए कि जाके फिल्म देखो. वो होता था. अच्छा, अब इन्होंने पाउच ऑफ डगलस, व्हाट स्पेसिफिक, एक्चुअली आई वुडंट हैव गॉन इनटू पाउच ऑफ डगलस, बट समटाइम्स you know, that is notorious for secondaries after a malignant ovarian tumor has been removed or debulking surgery has been done. Sometimes that's where the deposits occur because of gravity or whatever. So in a case like the one that we have discussed right now, I wouldn't expect Pauch of Douglas to be of any significance. But if you look into it and you want to see something, you want to rule out the presence of deposits. So wherever you look in cases of suspected ovarian carcinoma or in cases of ovarian tumor, you look for deposits to areas which are suspicious looking, from which you can take biopsies. And that's why it goes on to that extent in cases of malignancy that you take biopsies even from normal looking endometrium, so that you can identify that how far that has any changes in that. So we are thinking this is border. No, I am not saying that it is borderline tumor. I am not saying that. What I am saying is that we will discuss borderline tumors and malignant tumors in next session.
Sir, लेकिन इसमें staging का प्रोटीन तो की है ना?
हाँ.
और करने के बाद it was a even simple CYST, वो management के point of view से पूछ रही है.
हाँ, management point of view के बाद. अच्छा, अब staging laboratory जो है उसके there are points. Let me get you those points also. मैं points आपको लिखा देता हूँ, वो points. हाँ, ओवेरियन ट्यूमर्स की जो आपने चीजें देखनी है वो इसकी आपने पैथोफिजियोलॉजी है, पैथोलॉजी रादर, नंबर 1. नंबर 2 आपने इनका देखना है क्लासिफिकेशन. अभी मैं आपको क्या बताने लगा था,
मैनेजमेंट ऑफ
स्टेजिंग
स्टेप्स. कंफ्यूजन इस वजह से क्रिएट होती है कि वर्ड ऑफ मैलिग्नेंसी है वो बॉर्डरलाइन के लिए यूज करते हैं स्टेजिंग लेप्रोटमी, लेकिन सिंपल में हम जैसे बीच में आपने कहा है कि
मैं अभी आपको भी बता देता हूँ. स्टेजिंग लेप्रोटमी है जी, उसके स्टेप्स आप लिख लो, बाकी डिटेल आपको बताऊंगा. नंबर 1, careful evaluation of all peritoneal surfaces. Number 2, retrieval of any peritoneal fluid or ascites. If there is none, washing of the peritoneal cavity should be performed. Number 3, infracolic omentectomy. Number 4, selective lymphadenectomy of the pelvic and para-aortic lymph nodes, at least ipsilateral if the malignancy is unilateral. Number 5, biopsy or resection of any suspicious lesions, masses, or adhesions. Number 6, random peritoneal biopsies of normal surfaces, including from the undersurface of the right hemidiaphragm, bladder reflection, cul-de-sac, right and left paracolic recesses, and both pelvic side walls. Number 7, total abdominal hysterectomy and bilateral salpingo-oophorectomy in most cases. And number 8, appendectomy for mucinous tumors. ये है. You see, but मैं फिर वो दोबारा से वापस आ जाता हूँ इस केस के ऊपर, that if clinically it is, and on examination at the time of laparotomy, it looks like a benign tumor with no adherence and those features of appearance of a benign tumor, then you don't get into all that, because all those steps increase to morbidity of the patient, and in that it would be unnecessary. So I would limit it to peritoneal washing, removal of the tumor, and biopsy of the omentum. If there isn't anything other than that, if generally it looks like a benign tumor. Achha, what tumor markers, as this patient has benign ovarian cyst, she is below 40 years of age, what type of tumor marker we need to ask in this? In this patient, I would ask only for CA 125, because that is raised in most of the serous tumors. और कौन सा होता है, वो जो अल्फा फेटोप्रोटीन है और HCG है, वो यूजुअली यंगर एज वाले पेशेंट्स में होता है. CEA जो है वो होता है उन पेशेंट्स में जिनमें एक सेकेंडरी ट्यूमर है, इट इज फ्रॉम स्टमक और इंटेस्टाइन एटसेट्रा, वहां से आता है. And clear the concept of frozen section. Frozen section is something that is you take a biopsy and the pathologist kind of makes a block right over there, freezes it, makes a block right there, and also cuts a section and sees. The report is available within an hour or so. So you will have to kind of hold your surgery at that point, wait for that, and then resume the surgery in light of the report of the frozen section. Role of pre-operative ovarian tumor biopsy. Well, if you are going to do that, then you just go on to do laparotomy. There isn't, I wouldn't do it, just laparoscopic, say, biopsy of that. And if the contralateral ovary, in, for example, this patient, if it looks normal, there is no point in taking a biopsy of that as well, because that will further compromise her chances of fertility. And especially in those patients in which fertility is required to be retained, then I would not touch, or I would rather not damage in any way the normal looking contralateral ovary. ठीक है, ठीक हो गया, 9:40 हो गया काफी. चले बाकी सवाल आप लिख के रख लीजिए. Thank you very much for your participation. I hope it is of some use. One thing that I can recommend to you is that get on to an article which is FIGO classification of ovarian tumors. FIGO revised its classification of gynae tumors, gynecological oncology in 2018.